Good evening, everyone present here. I am Faraz from IGCP Group. Welcome all the participants on today's webinar in acute ischemic stroke on the occasion of World Stroke Day. As we know that this topic is a very much important, so we need someone who is expert. So without any further delay, I would like to invite our speaker for this webinar, none other than Lieutenant General Dr. C. Narayanan sir, and let me share some of the achievement of sir. Sir has done MBBS, MD in Medicine, DM in Neurology, and Chairman Manipal Institute of Neuroscience, Delhi, President of AIMS, Jammu. So without any further delay, I would like to invite Sir and hand over this webinar to Sir. Sir, the stage is yours. You can proceed from here. Over to you, Sir.
Thank you so much. Thank you, Faraz, for introducing me. As we all know, today is World Stroke Day, and it is an appropriate time to revisit some of the most important aspects of stroke management. The topic given to me is reperfusion strategies in acute ischemic stroke, current concepts, and evolving paradigms. Firstly, let us understand what is the burden of stroke worldwide. Stroke is the leading cause of death and disability. It accounts for nearly 11% of global deaths. Ischemic subtype dominates worldwide patterns. It is also noteworthy that 1 in 4 adults may have a stroke in a lifetime. So that's a very large burden. And this reflects the cumulative vascular risk, especially in aging and hypertensive populations. Of all the strokes, ischemic strokes form about 80 to 85%, and these are primarily due to thromboembolism from large vessels or cardiac sources. Management is very much time dependent. Each minute of delay destroys about 1.9 million neurons, so rapid intervention is very crucial. What about the pathophysiology of ischemic injury? As we all know, an occluded vessel immediately leads to infarction of portion of the brain, and this portion of the brain which is permanently damaged is called the ischemic core, and this core undergoes necrosis, but there is a penumbra around it which remains viable but functionally impaired. There is ATP failure and excitotoxicity, which leads to energy depletion that lead to failure of the sodium and calcium pumps, and also glutamate mediated toxicity. There is also inflammation and oxidative stress. There is microglial activation, reactive oxygen species generation, and this expands the ischemic core. The main principle of reperfusion strategies is to salvage the penumbra. Reperfusion halts the progression and preserves neurological function. So as we said, re-establishing the blood flow remains the primary goal of reperfusion. This restores oxygen and glucose delivery and clears metabolic byproducts. We want to prevent the infarct growth that limits secondary ischemic cascade and infarct core expansion. So IV thrombolysis and mechanical thrombectomy are accepted procedures of reperfusion. This is done by either pharmacologic clot lysis or mechanical retrieval of the clot from large vessels. Imaging plays a very important role in acute stroke management. It has shifted the fixed time windows to perfusion-based tissue viability models. In brief about the evolution of reperfusion therapy, in 1995, the NINS-TPA trial landmark was published in the NEJM. This established that early IV tissue plasminogen activator significantly improves outcomes. Thereafter, several studies, the ECAS, the Atlantis, and Epithet, extended the window period to 4.5 hours and validated imaging guidance. In 2015, Mr. Clean study and its successors proved that endovascular thrombectomy is efficacious in large vessel occlusion. So, now we use either IV thrombolysis or EVT, either sequentially or combined, and these have improved outcomes tremendously. The time window concept is very important to understand. The golden hour for IV tissue plasminogen administration is 0 to 4.5 hours post onset of the stroke. It is also important to remember that earlier administration yields maximum benefit. So one must not go by this concept that 4.5 hours is okay. Earlier the better. As I said, each minute delay causes a loss of 1.9 million neurons in the brain. Beyond 4.5 hours, we can also thrombolize with imaging as a guidance. And thrombectomy can be done up to 24 hours. These have been validated by the DAWN and the Diffuse 3 extended EVT based studies, and these are based on tissue criteria and imaging models. So we have to use both the time and the tissue model, and this merges clinical onset with physiological imaging parameters. What about the eligibility for IV TPA? Firstly, the clinical criteria, there should be a measurable deficit. Typically, there should be NIHS score of more than 4, and the stroke symptom should be disabling. It is very important to exclude hemorrhage by doing a CT scan before we proceed with thrombolysis. As I said, the timing is within 4.5 hours, and earlier initiation correlates with improved modified ranking scales outcomes. Contraindications include intracranial bleed, recent surgery, and severe hypertension. There are several other contraindications, but I will not delve into those details because of want of time. Aspect scoring, which stands for Alberta Stroke Protocol Early CT Score, is a 10-point score. So the lower the score, the worse the outcome. Again, I will not go into the details of the aspect scoring, but we must remember that 1 point is subtracted for every area which is infarcted in the brain, which are specified areas, either in the supratentorial compartment or in the posterior circulation. Imaging biomarkers are very important. Like I said, the core and penumbra can be differentiated, and this guides clinical decisions. Cerebral blood flow of less than 30% defines infarct core on CT perfusion studies. Cerebral blood volume and Tmax guide the tissue salvageability. That means these indicate the penumbra. Quantitative thresholds have improved precision tremendously. It is also important to note every patient is different. Collateral circulation determines infarct growth rate. Robust collaterals prolong penumbra survival, and these are visualized on CT angiography or multiphase CT angiography. They predict the success of EVT and also the risk of hemorrhage. What is the mechanism of action of TPA? TPA catalyzes plasminogen to plasmin, and this conversion lyses the fibrin clot. It restores vessel patency and enhances cerebral perfusion and oxygenation. There is a risk of systemic and intracranial bleeding due to the loss of clot specificity and fragile vasculature. Tenecteplase is emerging as a good alternative, and this can be given as a single bolus. This is fibrin specific and has a much longer half-life. So it can be administered as a bolus and not as a bolus and infusion like TPA. So what are the comparisons between tenecteplase and alteplase? As I said, tenecteplase is a single bolus agent. It simplifies administration and reduces door to needle time. In fact, in several stroke care models, it can also be administered while the patient is being shifted to the hospital by paramedical staff. It has greater fibrin specificity and a longer half-life. It enables sustained fibrinolysis with less systemic exposure, thus reducing the side effects. Recanalization is comparable or superior to alteplase, and trials show higher first-pass success in EVT candidates. It is now preferred in many stroke care protocols, and it has been adopted by the European Stroke Organization and also in Indian stroke guidelines. So as I said, tenecteplase is increasingly being preferred. It is given as a 0.25 mg per kg bolus in the window period of 4.5 hours. And as I said, it leads to higher recanalization and simplifies logistics in emergency settings. The clot composition is very important. Some of the clots are fibrin rich, some of the clots are RBC rich, and they respond differently to thrombolysis. Fibrin dominant clots resist TPA and usually need endovascular treatment. Histological type affects imaging appearance, impact strategy for thrombus removal as well. Now we are talking about extended time windows. Perfusion imaging defines viable penumbra. They use very specialized MRI protocol which may not be available in all centers. So CT perfusion and MRI mismatch guide therapy beyond 4.5 hours. And as I said earlier, the Dawn and Diffuse trials were the landmark trials which expanded the EVT to 24 hours in centers where specialized imaging is available. Otherwise, the window for mechanical thrombectomy still remains at 6 hours in centers which do not have these facilities. Tissue viability now outweighs strict time limits, and this is a very important concept to understand. What are the complications of IVTPA? Firstly, there could be symptomatic intracranial bleed, which occurs in roughly 6% of those who are thrombolized, and it is predicted by a large core volume or hypertension. Systemic bleeding can also occur, but it is uncommon. So we must always monitor sites and hemodynamics post-infusion, and we must refrain from giving too many intravenous injections or intramuscular injections after thrombolysis. Orolingual angioedema is not uncommon, so one should be aware of this complication and it should be promptly treated with antihistamines and steroids. Strict adherence to protocols minimizes the risk of complications, and so we must always follow the dosing protocols for thrombolysis. Post-reperfusion, we have to monitor the patients carefully. We must repeat a CT or an MRI after 24 hours. This will help us in detecting hemorrhage, infarct expansion, and edema, all of which have an impact on the outcome of the patient. We must monitor the NIHSS and consciousness trends of the patient, and all these are critical for early complication management. Blood pressure is a very important parameter that should be monitored and corrected if need be. Post-TPA systolic blood pressure must be kept at below 180 and diastolic below 105 millimeters of mercury. This would prevent secondary hemorrhage and hemorrhagic transformation of the infarct. Post-EVT, we have to maintain a mean arterial pressure for good perfusion. So we must not drastically reduce the blood pressure also. So aggressive lowering of early has an impact on patient outcomes. I will skip this slide. Reperfusion injury also occurs in some patients. It occurs after rapid flow restoration, reactive oxygen generation, and the blood-brain barrier disruption of the key mechanisms. This may cause edema or hemorrhagic transformation of the infarct. So we can use antioxidants and good blood pressure control strategies as we have discussed earlier. Now we come to the indications for mechanical thrombectomy. The indications are a large vessel occlusion. Primarily, initially, it was limited to the internal carotid artery, but now it's being expanded to even the M1 territory and beyond. Some centers also use mechanical thrombectomy for as distal vessels as M2. So this large vessel occlusion is confirmed by CTA and MRA imaging. NIHS is greater than 6 and aspect greater than 6 are the parameters which ensure viable tissue and clinical relevance of mechanical thrombectomy. As I've said earlier, the 6-hour standard window is always available, but this window can be extended to 24 hours when specialized imaging centers and protocols are available. The imaging parameters are based on perfusion core mismatch thresholds. So the decision to either thrombolize, offer mechanical thrombectomy has to be done in multidisciplinary coordination, and this can be done very efficiently when there is good communication between all the specialists who are treating stroke patients. As I've said earlier, the landmark clinical trial for mechanical thrombectomy was Mr. Clean, which was published in 2015. Thereafter, the ESCAPE, Extend 1A, and ReVascat and the SWIFT Prime trials validated their use. The Dawn and Diffuse 3 trials extended the treatment window to 24 hours with imaging selection. So, mechanical thrombectomy has now become the standard of care for anterior large vessel occlusions. What is bridging therapy? Sequential IV thrombolysis followed by endovascular treatment is called bridging therapy. This ensures early microcirculatory flow and also reduces the clot burden before retrieval by mechanical thrombectomy. So this bridging is standard unless in some centers the patient is directly wheeled into a suite where mechanical thrombectomy can be done. So there are various anesthetic considerations while we have mechanical thrombectomy. There could be a choice between general anesthesia and conscious sedation. However it may be done, hemodynamic stability is very vital to avoid hypotension and prevent secondary ischemia. Airway management readiness is very important, and anesthesiologist is always an integral part of the stroke care team. What about antithrombotic medications after you've thrombolized or done mechanical thrombectomy? Antiplatelets are not given immediately after thrombolysis. They should be deferred for 24 hours. And once we have ensured that there is no post-thrombolysis hemorrhage. Early dual antiplatelet therapy remains the standard if endovascular treatment with a stent is performed. When the patient has atrial fibrillation, we can restart anticoagulation after 3 to 14 days, depending on the size of the infarct and risk factor assessment. So, as I've said, we should not give antiplatelet for 24 hours. Early DAPAT should be given if stenting is done. Anticoagulation should be not deferred for too long for patients with atrial fibrillation. It is also important that the patient is monitored in the neuro ICU for at least 24 hours until a repeat imaging is done. The patient may require additional measures for management of edema and seizures with mannitol or hypertonic saline as needed. It is also important, like in all other stroke patients, to start rehabilitation early, and we must mobilize the patient within 48 hours if the patient is stable. Secondary prevention measures for control of risk factors and initiation of statins go hand in hand with reperfusion strategies. There's some special populations that require mention. Thrombolysis in patients who are 80 years and beyond have certain caveats attached to them, but this population should not be the right thrombolysis if they fit into the inclusion criteria. Wake-up strokes are another important consideration, but now even wake-up strokes can be managed if there is an MRI showing flared DWI mismatch or CT perfusion selects these patients for thrombolysis. Posterior circulation can be managed as well as the anterior circulation with thrombolysis, and increasingly for posterior circulation large vessel occlusion like the basilar artery, endovascular treatment has been shown to improve survival. Pediatric strokes are also being examined for thrombolytic therapy because there is a substantial population of children who have strokes. As I said, basilar thrombosis can be catastrophic if untreated, and EVT done within 24 hours improves survival. Thrombolysis is only modestly effective in the posterior circulation when done alone, and this requires individualized decision making. In some patients, we can thrombolize even beyond 24 hours. This is very rare, but it's done only in very specialized centers where advanced perfusion imaging studies are done. Rescue angioplasty and stenting can all be done when there is residual stenosis post-thrombectomy. Intra-arterial thrombolysis can be used as an adjunct when mechanical retrieval is incomplete. So we've talked about rescue angioplasty for residual stenosis, intra-arterial thrombolysis for distal emboli, and tandem lesions can be stented when needed. So all these can be done when there is close consultation with the neurologist, the neurosurgeon, the neuroradiologist, and the neurointerventionist. So hybrid strategies are very much under evaluation and have been increasingly found to be very effective. As far as the guidelines go, the AHA 2024 guideline talks about IV TPA in the less than 4.5-hour window, and they have recommended tenecteplase as an alternative to alteplase. EVT should be done before 6 hours and before 24 hours when specialized imaging modalities are available. Bridging therapy is always recommended unless endovascular treatment is faster and feasible. This is not always easily available. Systems of care are emphasized. Pre-hospital notification and workflow optimization improve survival rates tremendously. Emerging adjunct to reperfusion are neuroprotection, sonothrombolysis, AI-based image triage, and mobile stroke care units, where pre-hospital CT or TPA delivery shortens door-to-needle time. We've already talked about neuroprotection strategies. And as I said, workflow optimization in specialized stroke care units is very important. We must aim to have a door to CT time of less than 20 minutes and a door to needle time of less than 45 minutes. And I'm happy to note that in our stroke care center at Manipal Hospital, we've been able to achieve these parameters consistently over the last few years. One-stop imaging suits reduce delays, wherein the patient is directly wheeled into a OT suite where imaging can be done, and directly the patient can be taken for either thrombolysis or mechanical thrombectomy as needed. So parallel processing teams is by all teams is critical, and benchmark driven protocols like we had talked about, the door to CT time and the door to needle time are definitely going to improve outcomes. What about outcomes and prognostic factors? Successful reperfusion results in 3 into better MRS outcomes. This depends, of course, on the age of the patient, the NIHS scores when the patient is thrombolized, the core volume, and the presence of collaterals. So all these parameters differ from patient to patient. So the outcomes are also going to differ from patient to patient, irrespective of what strategy of reperfusion we adopt. Symptomatic ICH remains a major limitation. The patients and their attendant must be counseled adequately before we proceed to thrombolize the patient. Talking about the Indian context, we have very limited centers for thrombectomy, and all these are concentrated in urban areas, and so a large population which resides in rural areas are denied access to the cutting edge of endovascular treatment. However, telestroke networks are emerging. The AIMS and NIMHANS models are expanding the reach of patients who are available for treatment. Tenecteplase is a low-cost, effective treatment, and as we said, it can be given as a single bolus and it reduces cost substantially. We must increase public awareness, and this very topic has been chosen today to educate both the public and doctors on some of the modern techniques of reperfusion. There is a campaign called FAST, which stands for facial asymmetry, arm weakness or numbness, speech impediment, and emphasize the needs for time. And we all know that emergency response teams have to be trained in stroke management as well. Future directions include extended window for reperfusion, combined IV and intra-arterial thrombolysis, AI-driven workflow optimization, and regenerative therapies in the form of stem cell research that explore neuronal repair post-ischemia. To summarize, reperfusion has transformed stroke care from therapeutic nihilism to realistic recovery. Evidence-based protocols have ensured strict adherence and improved MRS outcomes. Access which is equitable to all population, whether it be it urban or rural, is a challenge, but it is being increasingly achieved by innovative approaches. The goal is timely reperfusion for all. Universal stroke ready systems should be available worldwide. Take home messages are: first, time is brain. Every minute counts, so don't wait for the 4 hour or 4.5 window to expire. Thrombolize at the earliest, activate the stroke code protocol immediately. The right patient should be chosen for the right therapy. We must use imaging protocol to select the optimal reperfusion method. We must combine intravascular IV thrombolysis and endovascular mechanical thrombectomy, and these have been proven to be synergistic and they have been proven to be beneficial in meta-analysis. We must not only build the skills of the stroke care team, but we must build systems. So the whole institution must be ready to accept and manage stroke patients at the earliest for good success. Thank you so much for a very patient hearing. I am open to take some questions from the audience if there are any.
Thank you so much, sir, for taking out your important time and sharing your knowledge on this topic, sir. I definitely think this session knowledge is going to help all the participants on their practice too. Sir, we have received some questions, sir. With all your permission, shall we take these questions one by one?
Yeah, please do. Please do. I'll be happy to
The
answer
first
them.
question is, sir, sir, the first question is, what are the current evidence based on time window for administrating for thrombolysis and performing mechanical thrombectomy in acute ischemic stroke, sir?
Yeah, as I've said, this is a very important concept to understand. The time window initially was 3 hours for thrombolysis. Now it has been expanded to 4.5 hours. But having said that, we must achieve thrombolysis at the earliest, because for every minute loss, there is going to be loss of viable tissue in the brain. So we must not follow the 4.5-hour window concept too much. And we have also spoken of expanding this time window when specialized imaging protocols show viable penumbra around the ischemic core. And talking about mechanical thrombectomy, the standard of care is 6 hours, and this can be done either before thrombolysis or after thrombolysis. And with specialized imaging protocols, which have been validated by the DAWN and Diffuse 3 studies, the time window has been expanded to 24 hours. And there are some situations, like I've said, in very specialized centers, people have even stretched the limit even beyond 24 hours.
Thank you so much, sir, for answering this question, sir. Moving forward, we have another question, sir. We will take second question based on this topic, sir. How should clinician approach patient selection for endovascular therapy when imaging shows a large core intact or delayed presentation beyond 6 hours?
So when there is a delayed presentation beyond 6 hours, there are still candidates for mechanical thrombectomy, provided we can demonstrate a diffusion perfusion mismatch showing viable penumbra around the ischemic core. And a lot of parameters are important, and these have been defined very clearly in the DAWN and diffuse trials. And when the software is called rapid software. So when that rapid software is available in your institution's MRI center, then we can proceed to do mechanical thrombectomy even up to 24 hours after the onset of ischemic stroke.
Thank you so much, sir, for answering this question, sir. As I can see, there is no more for questions, sir. I hope, sir, you had done justice to this topic and able to solve all the queries related to this topic. And sir, one feedback from Dr. Anshuman. He has written very important topic. Thanks for taking it forward. Sir, as
Thank
there
you
is
so
no
much.
more questions, sir, with all your permission, shall we conclude this webinar for today?
Yeah, thank you so much, Faraz. It was a pleasure
Welcome, sir,
talking
and sir,
to
we
the
would like to
audience,
see you
and
in future also with.
you for organizing the session.
Yes, sir, and we would like to see you in future also with different topics, sir. Till then, take care. It was great honor to host you, sir. Thank you.
Thank you so much. Good night.